I may not be able to do that topic perfect justice. But the idea is that if in osteoporosis, patients who've been stopped in their exposure to denosumab or Xgeva sometimes have an increased risk transiently for hip fractures. And so there's a concern about extrapolating that to myeloma. I know of no actual clinical data on denosumab and that increased risk of fractures on stopping denosumab, and I tend to use Xgeva, denosumab, and Zometa primarily in patients whose myeloma is out of control. I don't take any special steps once they stop that treatment to further decrease the risk of fracture. I have recently, in the past 9 months, for patients who were Xgeva naive, pre-treated or started at the same time, giving them high-dose vitamin D, so ergocalciferol, 50,000 units twice weekly for a month, along with oral calcium supplementation to decrease the risk that they have symptomatic low calcium levels, as Xgeva is a slightly stronger version of Zometa, so you're at higher risk of lower calcium levels than Zometa. But I don't have anything else on the stopping of Xgeva.
Yeah, I try to use Zometa as much as possible. You don't have that issue to the degree of do you have bone loss when you stop it. You can give there's data on Zometa every 3 months. I think the current NCCN guidelines just say when you get active myeloma, you use 2 years of bone strengtheners, and then you kind of decide what to do. If there's any concern on cost in cancer treatment, when they are nearly identical as far as effectiveness, I would tend to choose the agent that's $60 a month versus $2,400. And again, another reason I use Zometa. So that doesn't come up often that I need to use Xgeva. It's usually renal insufficient patients or somebody who's having really big problems with the Zometa for some reason. And again, I usually leave them on for a year or two, and if their disease becomes quiescent, then I take them off because I really don't want to leave them on a shot their whole life necessarily.
So I've not seen problems stopping Xgeva. Like I just, it's not like I've treated thousands of patients, but I've just not had problems with it. I think that there are issues when you're on it that you can see pretty low calciums. So I think you have to be pretty vigilant about that. But in terms of, tolerability, once you stop it, I haven't had many issues. I too tend to, slow down or try to get people off. If they've been in a remission for a while, I think it's time to maybe tail back a little bit. But like I said, I haven't had increased fractures, anything like that.
CRISPR is a gene editing tool. It's still not a incredibly precise, but increasingly precise way of doing gene editing, and having CRISPR used, having cells removed from a patient, gene edited, and then reinfused back is a relatively new modality of treatment internationally for blood cancers. And the first couple patients in blood cancers we're going to hear more from next month about how they did and exactly what they did. And it is a direct modification of these cells. Similarly, there is a way to edit myeloma or edit cells through chimeric antigen receptor, CAR T cells, and there, somebody's own cells are taken out, modified primarily by infecting them with a virus that forces these cells to put up on their cell surface a targeting protein, forcing them to seek and out myeloma cells, and because they're T cells, because they're mercurial and have no temper control, as soon as they get close to a myeloma cell that they're targeted towards, they basically explode in anger. And that's how the myeloma cells die. So it's taking a particularly temperamental immune cell and forcing it to run up to a myeloma cell. And every time they do that, they divide. So it's a time where a temperamental immune cell then expands or divides and becomes its own kind of self-renewing therapy, even though that's exhausting, as you can imagine. If you were very upset multiple times, it just becomes exhausting, and these cells can get exhausted from so much expansion. But that's a CAR T cell infusion, and CRISPR is a different way of changing the overall genetic message of these immune cells. And it's not just immune cells that CRISPR is used for. So the question was, hey, for AL amyloidosis, are there any new drugs under investigation? AL amyloidosis is a difficult complication for clonal plasma cells, just like myeloma cells. But these antibodies that are secreted by these plasma cells form into a sheet that can be deposited in a toxic way to primarily hearts and kidneys and lead to heart and kidney failure. But they can be deposited in any organs and lead to dysfunction. It can be deposited in the tongue, the muscles, the eyes, anything like that. AL amyloidosis requires that these clonal plasma cells exist. But different than myeloma, these clonal plasma cells are really in and of themselves causing the problem. They often eat away at the bone. In AL amyloidosis, just having those antibodies in this little formation, but they can slowly crush the normal function of your heart and kidneys and other organs. Genetically, AL amyloidosis is very similar to MGUS, except this is an MGUS where the circulating antibodies are toxic from the moment they occur. So there's a lot of new drugs in the AL amyloid space. Difficult to develop drugs in the AL amyloid space. Primarily, there's a drug CAEL, CAEL-101. I just looked at a phase 3 trial that's going to be start recruiting soon. There was some very interesting and exciting research done in London at UCL trying to pull up some of the amyloid fibrils that were deposited into organs, because like many diseases, once you've damaged an organ, everyone really wants to be able to fix it in some way. It's very difficult to do that in any organ that's been damaged through any means, through hypertension, diabetes, but also through AL amyloidosis. Doxycycline, there's going to be some information on that. It's an antibiotic given along with amyloid treatment, and those kind of definitive prospective trials incorporating the use of doxycycline in AL amyloid therapy are going to come up and be presented at next month at ASH, at the American Society of Hematology meeting. So there's a few drugs percolating around, but none, to my knowledge, is ready for approval right away. I'd be remiss if I didn't tell you that the other types of amyloidosis, the TTR amyloid, there's been 3 drugs recently approved in the last 18 months. So it's a whole new thing when people talk about evaluation for amyloid, and it actually will lead to increased diagnosis and better treatment for patients who have both TTR amyloid and AL amyloid, because now there's something that can be done for both of those patient populations. And so it's an improvement, even though we got a long way to go. Okay, so for CAR T cells, those CAR T cells used in the relapse refractory setting after 3 or more lines of therapy, usually they're 5 and 9 lines of therapy. Really end-stage patients are the ones that have been treated and described most often through CAR T cells made in China, made by Celgene, made by Janssen. All these companies, median progression-free survival, so median period of disease control is about a year. And when we got a lot of that data, we're like, wow, only a year? I thought this was going to be a cure. And everyone was kind of dismayed by that, but that's a year longer than the majority of these patients had, and that's just the first generation of CAR T-cell trials. As the next generation will likely incorporate multiple targets and interventions to improve the life of these genetically modified cells, as they tend to skip out and not be nearly alive as long, and some of the pushes through modifications about how you make these CAR T cells, and also through treatment in earlier lines of therapy and newly diagnosed and first relapse or right after autologous transplant when the patient's own immune cells are not as beaten up. Answer to your second question, I get this question a lot, and I often suggest to patients that unless they have two first-degree relatives, so a clear myeloma family with MGUS or myeloma, that I don't suggest additional testing. I do suggest that they not do what I do when somebody says, "What's your family history?" I just lie. I just say I have no family history. I'm orphaned. And, because I just don't want to fill out any more paperwork. And I just urge people not to be like me and to be upfront in your family history, because it does make a difference when you're in the ER and you feel terrible and you're hypertensive and your blood pressure's out of control and your feet are swollen. How are you supposed to know that you're in kidney failure and the family history of myeloma is something that can decrease suffering and improve the speed to diagnosis? So I just urge you, don't be like me, be honest.
I'll just tell you some personal experience with CAR T. We've just mostly anecdotes, some patients that we've again, very aggressive disease, and really nothing was going to work. We're referred for transplant. We referred them for CAR T. Marrow was packed with disease, and these cells just cleared it out. It was amazing, and the patients came back and looked great. Now, unfortunately, 3 months later, there was escape of myeloma again, and things started growing again. So I think, it's still early days for CAR T, and like Dr. Hoffmeister was saying, if you use it earlier in the course of the disease, you might expect something different. And there are so many researchers working on making these cells better, making it, lots of times one of the issues with CAR T is people are so sick, we can't collect cells from them, right? Like they don't have enough white blood cells, enough T cells for us to actually pull out. That requires having a machine to do that, having the technology to modify those cells, edit them, expand them. So all these areas are evolving. The other area is off the shelf. So if somebody just has these CAR Ts made beforehand and it's just sitting on a shelf, you need it, you can just go grab it and just infuse it. Now, there are a whole bunch of hurdles to overcome with that, because now you're using somebody else's cells. Are they going to get rejected by your immune system? People are working in different cell sources like NK CAR Ts from cord blood being done at MD Anderson. So a whole bunch of different stuff going on. And I think it's creating a lot of excitement, a lot of promise, but still early days. And I would agree, I would not test your children unless there was a very, very strong family history.
I agree with the things that have been said. The CAR Ts weren't as exciting results as we wanted compared to what some of the other disease states were getting the results. But it's just in its infancy, and we'll tweak them and they'll be better.
Yeah, I think that, if you look at the availability of CAR Ts now, like what we're treating with CAR T cells that are available, just, not within the context of clinical trial. In some diseases, in leukemias, you have a similar situation in myeloma where it looks like they're not a permanent fix. In lymphoma patients, it may be that up to a third of patients are patients who respond to them for a long period of time. And so I think that there are instances where you can get some durable control, like there's some disease states that may not be in myeloma, but at least you have evidence in other places that you can do that. So this is really like just the very, 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 very beginning. So just like, beyond having melphalan and prednisone, like the first drug was really thalidomide, and thalidomide is, was a earlier version of the things that we're using now. So there's a lot of room for improvement. There's a lot of research going on. I think that, there was one study that was done where a lot of times to make the CAR T cells, you use a virus that has a piece of DNA, and that injects the DNA into the tumor cells. And so there's a study done in mice where you just use the virus, and so you're making CAR T cells in the person, right? So that was published about 1.5 years ago. So I think there's a lot of great technology, and this is really just the beginning. So it's really figuring out what are the optimal conditions, how can you go and further add things to improve it. But as long as you're able to make them, you're starting to get them into people and you're starting to see responses, I would be optimistic. I think that it's a good place to start.
And what about, do you have thoughts also about having your children tested or having familial issues?
Craig has seen someone who's 16. I've not seen anyone really. I've seen a couple people under the age of 20. But I think, early on is rare. I think that, it's, I always say, because people say, well, I want this test. And I say, okay, what are we going to do with the results? So I think part of it is thinking about the results. I think that if you have a strong family history of myeloma, I think that it makes more sense. But if you're just going and screening every single kid, who's in 6th grade for myeloma, some of the tests are going to be positive, but they probably don't have myeloma, but you're going to have to do a lot to work them up. So I think it just depends on I think more of a family history for sure. I think you have to be more interested in doing it, but I don't recommend just sort of saying, look, we're going to test everyone in your family. I don't recommend that.
And think of the real numbers. So myeloma on average population is 7 to 8 per 100,000. So if your risk increases by three times, then you're talking about 24 per 100,000. So you have to keep that all in perspective.
So we've done compassionate use stuff. Like I've been a part of a number of cases trying to do that. It's definitely not easy, right? And I think that really, but if there are not really any good other options, then I think it's an option that should be pursued. I think that if you have, say, 5 other options, but you just think that this other one is better, it's going to be really hard to get a drug through compassionate use. I think that if you go to someone who has a drug, it's in studies, it's not available anywhere else, and you say, look, this person really has no other options, that's when I think that's when you have a chance. I think it's easier with drugs that are in later stages of development, like they've been through multiple trials. That I think is easier than if you have something that's only been tried in 5 people. That's a little bit more difficult. So there are parameters around that, but I think that it is, it's something to look into. I think that at the same time, this is one of the issues. Like we should have studies that are available for people with oligosecretory disease, right? Because not everyone fits into the box. And so part of what we talked about with clinical trials is they are pretty restrictive to some extent, and sort of changing the way we do them, the way we think about them. Those are things maybe hopefully that happen in the future. But that's sort of the way I would view it.
So this came up in my clinic on Wednesday as a patient who was relapse refractory, had 3 lines of prior therapy, and was looking to get access to GSK's antibody drug conjugate, belantamab. Belantamab is likely to head towards and apply, and maybe already in process of being evaluated for FDA approval. And she said, well, I know this drug is effective in myeloma. I'd be happy to take the risk. Can you help me out? And so they have an expanded access clinical trial available for belantamab. But every center has to have a confidentiality agreement. They have to have basically their own IND, all practically, and do all the paperwork required with the FDA and primarily with the drug company to get somebody belantamab. And so it's a lot of paperwork, et cetera. It's a lot of regulatory burden. Most important for the patient, it's time. As a doctor's working in the background to have all this signed by the institution to allow the belantamab to be safely given. The patient's myeloma remains untreated and uncontrollable for my patient. And then the problem is that the company doesn't want anything bad to happen to that patient. They would love to see the patient treated, love to see the patient's myeloma controlled, but the reason that they weren't able to get onto the clinical trial is most likely going to be the same reason you're not going to be able to get access to the expanded access trial. For the belantamab expanded access trial that I was just looking at, my patient wouldn't be eligible because she didn't have any platelets to her name, and for you, the concern is the monoclonal protein and measurable disease. Both of those are still in the expanded access. So while you can get expanded access to some of these drugs, many of the reasons you think about it are often not fixed with the expanded access programs. So it varies by the drug and by the timing. And it only really comes up in the late development of a drug that's not FDA approved. Boy, that's broad. Yeah, absolutely. Nanoparticles surrounding an interfering RNA molecule, patisiran, was recently approved for TTR amyloidosis. So that is one of the nanoparticle related therapeutics that's already FDA approved. It's not science fiction. It's out there. It's being done with patients. And I was just on a grant review panel with a lot of nanoparticles being contemplated in a number of cancers. I'm not aware, and my colleagues may be better aware, of a nanoparticle related delivery system of a drug or genetic code for myeloma or any patient with plasma cell disorders. I think that the science fiction-y part of all this is a lot related to cell therapy and gene editing therapy, immune and oncolytic, potentially oncolytic virus therapy. I'm the only one here that's excited about that. But still, it's trying to see, things that are now available for patients with hemoglobinopathies and sickle cell, et cetera, thalassemias that were kind of unheard of 10 and 15 years ago. And these patients are walking around no longer transfusion dependent, living a totally different life. So the potential for that in myeloma is certainly very attractive, but it's hard for me to tell you an immediate next step.
The only thing I'm aware of is nanoparticle-mediated delivery of RNA and DNA molecules. So to immune cells, to make CARs, things like that. I'm not aware of anything directly targeting myeloma.
Before you answer, I'm going to switch mics with you. I've been asked to. I don't understand why, but there we go.
All right. Yeah, I'm in the same boat. I don't know much about nanoparticles. And as far as new agents, I think that there's several things still being looked at. I think even just tweaking what we got, just like it was a big advance to go from thalidomide to Revlimid. Daratumumab works pretty well, and there's new anti-CD38s coming out. And if they can work even better, can you get even a deeper remission, cure people with what we've gotten just tweaking? So there's a lot out there, but unfortunately, most things, like I think I alluded to, fail. Most times when I'm talking to a phase 1 company, this is agent number 3,000 that they're finally getting into clinical trials. Right? They've looked at 2,000 other molecules and they've all failed. And that's real common, and most phase 1s fail, and most phase 2s fail. So, you'll see these New York Times articles that say we've cured cancer in a mouse. Every single agent I have has cured cancer in a mouse, every single one. So it's really complex when you get out into people. And so There's a lot of things going on. We have trials that arginase inhibitors, anti-CD74 antibodies here, and they look great, right? But are they going to be the next thing? I don't know. We'll see.
You know, I think beyond the science fiction of viral mediated therapies, but I think that I had, when I was at my former place, there was someone who was a lung cancer physician. His name was David Ettinger. He was advanced in age, and he said that what we needed to do is we needed to invent a machine that turned a human into a mouse, because then we could treat their cancer and then turn them back into a human. That would be the one thing to do. I think that as far as therapies go, I think that there are exciting things, like, you know, the way that lenalidomide works had not been known for many years, and what it does is it selectively allows specific proteins to be chewed up. So it doesn't chew up every single protein, it just chews up some. And so there's a lot of, there's now thoughts of a lot of technologies to target proteins in that way. So you don't sort of just obliterate everything, you go after very selective things. I think that's going to be really exciting. I think the ability to sort of modulate what proteins get turned on and turned off in cells is going to be much, much better as we move forward. So it is like, you know, there are all of these predictions about how many ideas or how many drugs actually make it there. But, you know, I think we would all agree that myeloma is treated really differently now than when we started out. And, you know, it's really those types of advances I think will move things forward. But so I think I'm optimistic. I think that we made a lot of progress. There's a lot more things to do, but I think we can get there. Yeah, so you know, Jason talked about that a little bit. That's the idea of combining, you know, two sort of sticky things. One thing sticks to the tumor cell, and then the other thing sticks to T cells. And so the way that, or immune cells, and so really the way that the immune system works is it works through T cells. So you need T cells, it goes up to cells, it kills those cells. So using a BiTE, which is this bispecific thing, and where you bring T cells in the midst of tumor cells, can have some activity. And so there is a drug that's available for leukemia, for a specific kind of leukemia. And that drug is actually quite effective. It has some of the same side effects as CAR T cells does, but it's not typically, maybe not as severe, but it has some similar things. So we've used that a lot in the past. So I think that in myeloma, there is exciting data using BiTEs. And there are new BiTEs being generated. One problem with them is the one that is available now is that you need to continually give it. So you need to wear a pump that sort of pumps it into you. And I think that there have been, you know, advances where maybe you can just get it once a week, just like any other drug. So I think that may be something, as Jason was saying, like a bridge between like using just antibodies and using CAR T cells. Like that may fit nicely in the middle. And so that may be, you know, a really, like I said, it's in the clinic standardly for patients with acute leukemia. And so I think that that's a possibility in myeloma for sure.
You know, I agree. Just what he said. It's the first BiTE that came out is really logistically challenging when you have to constantly infuse it. I think you can only, you're not even supposed to go off it a few hours, so home health has to come and hook it up for a lot of people, et cetera. So the hope is the newer ones, just like in the CAR Ts, are going to get better, and you can just infuse them in the office, and you don't have to do the constant infusions, and there won't be quite the reactions. And we've got one that's supposed to come like that, that's saying BCMA like a CAR T. Supposed to be here January, I believe, but it was supposed to be here in May. So that's what happens a lot with clinical trials. Every month it's the next month. So I hope to have it in January, but I'd be excited to use it.
Yeah, no, I agree with everything that was just said. We use the BiTE for leukemia quite a bit prior to transplant, getting patients into deep remissions. And it is quite cumbersome because of the continuous infusion the potential toxicities. A lot of the toxicities are very similar to just what you see with CAR T cells, so it requires very specialized nursing care, inpatient hospitalization. So if it can be converted to something that's more outpatient friendly, infused once a week, and there are definitely strategies that are being worked on, and myeloma might be a better disease to do that in, because even with CAR T, the CRS rates in myeloma are a little bit better than what we see in leukemia due to a variety of reasons. So.
So I think about this daily. I'm the research lead for the area. How do we get more people on trials? We put 100 and some odd on treatment trials a year in Austin. That's actually considered a lot for a community practice. It's way under what we should be doing. And shuttles. So yes, we came up with that idea. Let's do shuttles and get people in. That's considered an inducement. So our legal team says you can't do that. Same with all the other issues. Legal states you cannot induce patients to come to your clinic, and can you not induce them through that method. So we can't do that. Would love to do it. Doesn't cost us that much. Not doable. Been talking about that for 10 years and talked to multiple people about it. So, you know, as a business, we can't take legal risks like that. There may be some clinics that can do that. I have seen some independent people do that, but our legal won't let us do that. Could I open all of my centers to clinical trials? We only have 4 centers open in Austin. We tried that too. Data quality goes down when you try to do that, at least in our setting. So it's something I literally think about daily, and we have meetings on it, and we just had a meeting on it last week, and meet with US Oncology about how to increase our accrual throughout the network. But it's tough. I wish we had better ways to do it. But it is. Even in, I used to go out to a community clinic about 30, 40 miles from here, but I would talk up my trial, say what I wanted to do, and a lot of people just, I'm not going to drive into Austin. I am not doing it. And there's not much I can do about that, even though I knew the trials, I knew the drugs very well. So I struggle with it a lot, and we constantly work on it. Yeah. I don't know if anybody.
And 2 small plugs is that the website Spark Cures is a great clinical trial search engine specifically for patients with plasma cell disorders. So trying to find access to trials is sometimes the first step. And the second step is an educational perspective, is that many people are still very, very suspicious of clinical trials. Clinical trial enrollment is basically old white men. And that represents an educational deficit on our part. And as we have not proactively gone out and talked to people to try to tell what clinical trials are like now and how they're different from 100 years ago. And we need to do that more. So that a nudge, in my view, would be an educational push for both physicians who think clinical trials are only meant as the last resort for patients, to patients who think that they're a physician's guinea pig. That's an educational deficit for both patients and physicians.
Like, I think part of it is, like, you know, if there's a culture of doing clinical trials, right, of people participating and people saying, look, it's not a bad thing to do, it's actually a good thing to do, it's sort of getting that's the nudge. You got to get people to start thinking that that's the way that they really get the best treatment. I think that, like, you know, we had, you know, at the Dell Medical School, we had a conference about, I want to say about a year ago, and it was really one question was, Jason was at it, one question was like, how do we get people to do clinical trials? And I think part of it is that it's funny because, like, you know, what I think the barriers are, or what Jason might think the barriers are way different than what the actual patients think the barriers are. So we have a community focus group that really is trying right now to come up with strategies, like educational strategies, to help participation and figure out the ways to deliver the message about clinical trials. So that's something we're very interested in at the medical school. But it's great that we had this meeting, and it's like, I think that we're on the verge of trying to implement some things, but it is not easy. It's not easy to change the perception of trials. It's not easy to convince people that these are the best things to do. But, I think that if my guess is you build a culture of that's what you do. That's what we're known for. If we're known for doing clinical trials, you're going to come for clinical trials. But I think that things like Spark Cure help you really, get over the barrier of having to call 50 places to find a trial for yourself. That really helps out a lot. And so having good places where you can find them, having good ways of like communicating to see if you can get on them, talking to other people who are on them, participating in trials. I think all of those things, it's really like communication that's the key.
Well, before I thank everyone, I want to just mention about clinical trials. So I help patients almost on a daily basis, just with HealthTree and other things. And somebody came to our office. She was 85 years old. Her doctor, she was being treated at an academic center, but not by a myeloma specialist, but it was a myeloma academic center. And she had had 2 prior lines of therapy, and she said, the doctor said that you should go like pack up and get your affairs in order because there's nothing left for you. And after we went through HealthTree and showed her here are all the treatment options you could consider, and here are all the clinical trial options you could consider. And she was dancing every week, multiple times a week. So she was highly fit and still raring to go. And she said, that's so amazing. So just talking to one another in the clinic, if you meet a myeloma friend in the clinic, you should be talking about clinical trials as an option. It's not the last resort. Please don't wait till the last resort to consider a clinical trial, because by that point you may not be eligible. So share. I think it's all up to us to share in a support group situation, in the clinic, with a friend of yours. If you hear about somebody diagnosed, you should consider a clinical trial at every stage of disease. Even a newly diagnosed patient could consider that.